Well, good afternoon, everybody. Welcome to the Care Quality Commission public board meeting this afternoon. My name is Ian Dilks. I'm the chair of CQC, for those that I haven't seen on these broadcasts before. I won't introduce everybody who's here today, and many will be familiar faces to you. There is one I will introduce who we usually, as you know, have an equality network representative. So today it's Hannah Carson over in the corner there, if the camera's captured her, and she represents the Gender Equality Network. So welcome, Hannah. We have one apology. Sean O'Kelly can't be with us. Sean, you recall, joined us a few months ago, but he already had a long pre-arranged holiday booked for this couple of weeks. So he sends his apologies. I don't know if he's dialing in from vacation to watch us. I suspect not. I will comment later on, but I should also say that this is the last board meeting for Sir Robert Francis, who'll be standing down as the chair of the Health Watch England and also as a member of the board. But I'll mention that right at the end of the meeting as well. I haven't been notified of any new conflicts of interest prior to the meeting, as far as I look around the room. I don't see any more. And I haven't been notified of any urgent business to put on the agenda, so I suggest we move straight into the topics. Today's agenda is very much focused on reporting updates on what is going on in the organisation. We have no major strategic discussions today. So if it's okay with everybody, I suggest we just kick off straight away with a report from the executive team. There is a slightly different format to this time, which, Ian, I'll hand over to you to explain that and then take the comments. Thank you.
Thanks, Ian, and good afternoon, everybody. As Ian's just alluded to, we normally do we've normally done a single report that talks about individual sectors in the Chief Exec's report. However, I think reflecting our move towards looking at both sectors and systems and the recent internal moves that we've made to create the regulatory leadership function alongside the operations group, we've split the Chief Exec's report now into regulatory matters and organisational matters. So I hope that gives a more joined up, more collaborative view of what we as an executive team have been doing, and it enables us, I think, to more coherently reflect the work that we've been doing. So as always, I think I would ask you to take the report as read. Obviously, very happy to answer any questions. I think the broad comment I would make is that the report reflects that the health and social care system is under significant pressure at the moment. I think that's something that's been widely reported, and we know that can sometimes translate into poorer care for individuals. And whilst that can often translate into a regulatory response, a formal regulatory response, I think, and we'll cover the details off in the next item when we look at the performance reporting section. I think what we have also done is taken the opportunity to look for where things are going well and looking for examples of good practice. And I think, products like the People First product and the work we've been doing in maternity and elsewhere are really good examples of that. And I'll bring Chris in a moment to talk about that. The other thing to say is, although we've got the most recent performance information in this section of the report, I think the most sensible way of dealing with that is to invite Tyson to do that as part of the quarterly performance reporting. We usually, as you know, deal with the most recent month in this section and then quarterly reporting. I think just bringing those together would probably make the most sense. So can I just bring Chris in to talk about engagement matters?
Thanks, Ian. So three things just to highlight from this report. Firstly, as Ian said, we've been looking at how we might support organisations and systems in their planning for winter. Colleagues may remember we produced a document working with clinicians from across some outstanding organisations, a document called Patient First, which was looking very much at the secondary care response to the issues in urgent emergency care. We wanted to, and colleagues from across the system wanted to update that to reference the relationship between health and care organisations. So today we're launching People First, which is a look at how organisations work collectively to support the managing the flow within urgent emergency care, not just from within the secondary care environment itself, but also across the wider primary care and adult social care network. What I think it does, which is important, is it sort of obviously highlights the issues, but it brings together practical guides for organisations and people working in those organisations from their colleagues from other organisations. So we've acted as a convener for this, but it very much hopefully guides people early enough around the actions that they can take to support the organisation's planning and delivery during this winter period. So we know that the Patient First Guide received some strong support. I'm hoping for the same again today as we launched People First. Alongside that, just two of the things I wanted to quickly mention. We've been working for a number of months now. We've published a report on this some time ago on our concerns around maternity services, indeed highlighted by the BBC today. What I wanted to assure the board is that there is a strong focus on inspection activity in this area, and we intend, in a similar way to People First, to talk about the concerns we have and also where we see good practice in maternity services, what lies behind that good practice. So there are a number of, there's an inspection programme taking place now. We will update the board and indeed update colleagues across health and care with our findings as we go. Our intention is to look at all organisations that have not been inspected since 2019 and to talk about both ambition, where organisations are improving, and also our concerns where organisations are not. And lastly, just as part of our build-up to this year's State of Care report, we've done some work with an organisation looking at how people experience care across health and care. The project called 4,000 Voices sort of tracks people's experience of care across the primary care, secondary care and adult social care network. And I think it's what it practically does for us. It gives the voice of people who use services at the heart of what we will say in this year's State of Care. So I just thank colleagues for helping deliver that. It's been a tremendous undertaking, and I hope that not only will it show the areas of concern, but also, again, some of the good practice that we see in how systems and services are working together to deliver services for people. That's my thoughts, Ian.
Thanks, Ian. If I can also invite Kate then to talk about learning disabilities and autism, and then perhaps we can open it up for questions, Ian.
Thanks, Ian. So just one thing to draw out from my update today. So in our commitment to ensuring that right support, right care, right culture is being delivered so that people with learning disabilities and autistic people receive services in places that are small and based in the community, we've introduced a new way of putting conditions on new services registering with us that requires them to come back to us if at a later date they want to provide services for people with learning disabilities and autistic people. And this is to ensure that we are doing everything we can at the point that new services are coming into the market, that if they are for this group of people, they are meeting the requirements of right support, right care, right culture. So a new way of using our conditions that feels like another positive step in ensuring that we are making sure that there are the right services out there for that group of people. Thanks.
Okay, thank you very much, Kate and Chris. So perhaps I could open this up to any questions from colleagues around the table. Robert.
Thank you. Could I just say a quick word about People First? Because a number of things about it, but very briefly. Firstly, it's remarkable as being a document which not only identifies the very well-known problems of emergency care, but also solutions to some of those problems across the system. Even more encouragingly, it is based on the lived experience, in this case of one particular patient, but unfortunately who had a journey through the system that will be all too familiar to many people within it. But perhaps the most remarkable piece of it is that it's the use of the Care Quality Commission's convening power of there were 250 people involved in putting this document together, all of whom were senior clinicians in various parts of the system, all of whom were committed to change. And I think it's really important to emphasise that although we spend a lot of time happily identifying what has gone wrong, these are often issues for which there are solutions, and there is actually no need for people to despair. I can't say, as a non-qualified person in this field, as a lawyer, that these solutions are actually the ones that are going to fix the whole problem, but they certainly look like things that are going to go a long way towards that. So I would hope that this is a document, firstly, that is looked at seriously by those who can affect these changes, and secondly, that it will actually give hope to our hard-pressed health and social care staff who are going well beyond the extra mile in looking after people at the moment.
Thanks, Robert.
Just to echo that point, particularly around, I think, the fact that we've managed to gain support from such a wide variety of people across the system to make the report a practical guide is crucial. And as you rightly say, Robert, it hopefully gives hope to those at the front line of delivery of care this winter.
Thanks, Chris. Sally.
Thanks, Ian. Could I just come back to the maternity report? Because we talk about the wider ambition for our programme, and obviously what we've detailed here is quite comprehensive for CQC, but there are other bodies, aren't there, working on safety in maternity under the guise of DHSC, and obviously the new body which will investigate maternity incidents. Could you say a little bit more about what we've called our wider ambition for the programme? It's probably directed at Chris, but could be somewhere else.
You're quite right. I think one of the important features of this work is that it quickly disseminates what we see from our inspection activity to partner organisations who have a role in improving and shaping improvements in the way women receive maternity services. So we've already established the relationships, and our intention is to have a regular reporting of that information through to other partners. And indeed, there are some issues that we think we can collectively unlock. One of the conversations we're having with the GMC was a bit about the relationship and training support for people to work in multidisciplinary teams. And of course, this is a multifaceted issue that requires support from other organisations, and they were very keen to work with us on what that meant in terms of what they needed to say around their own support for their members. So I am keen that I believe we've got the right mechanisms in place to bring about that change. What I'm keen to make sure is at the point we hear things as we go through that inspection process, we're sharing information in real time with those other partner organisations so that they can take action. It isn't just about building up to another report. It is about real-time action to help both local organisations and national system leaders take the right action.
Chris, just since we're on the subject of maternity, before we move on, Sally asked most of my question, but also could you give us an idea of the timing of the national report that you talk about? And you also referred in your ESAG report to the fact we discussed it with them. I just wondered if there's any feedback from that meeting that would be worth sharing. Thank you.
So the ESAG support for this was quite strong. So ESAG is a group of people that represent both providers, people use services, and wider stakeholders. And I think there was support for this because there was a recognition that not enough was changing quickly, and a sense that this is a collective responsibility to do something about it. So I think the BBC report today reflects where we are at the moment. I think the challenge is how do we collectively move, and I don't think this is it's not a single facet, not a single problem. There's a multitude of issues there. That was recognised by ESAG. What we intend to do is we want to try and get through the inspection activity as quickly as possible, but we also want to make sure we are hearing from people who use services and staff in service as we go. So we'll probably have a number of opportunities to update board, the first one of those being in the early new year. I'm hopeful by the end of this financial year that we'll be in a position to provide a more comprehensive briefing back. But as I say, I want to use the information in real time to support the ongoing conversations that we have. So there'll probably be an early January and perhaps a later March update for the board. But I hope to use the information more in real time to promote the conversations with other parties.
Okay, thank you. Stephen had a question. Are you going to add to that answer or another question, Tyson?
Thank you, Ian. I was just going to add very briefly that in terms of the timetable for the inspection programme, we're hoping to complete it by spring next year, which fits very much in with the timetable Chris set out. And in answer to Sally's question, we see this as very much a contribution to the national improvement effort, and we will obviously work with all partners involved to try and particularly draw out innovation and good practice. Thank you.
Stephen, you had your hand up.
Thanks, Ian. Like Robert, I kind of wanted to welcome the what you say about people first. Looks like a really, really powerful way of using CQC sort of convening power, drawing people together, getting them to talk about what's working for them, what innovations are they making, sort of giving some solutions to some serious and system-wide problems. Do you see that as a one-off, or is that a model that we can now sort of roll out in other areas of sort of challenge across the system? Because it looks like a powerful thing to be doing, and I'm just sort of interested, is this now a model for the future that we could play out into other parts of the system?
A really important question, and I absolutely do see this as a model for how we could operate. I think to some extent, CQC is neatly placed to bring what we know about services across health and care together. And in this case, we're able not only to bring what we know, but the individuals responsible for delivery together and create a forum where they can debate and discuss practical steps that they can collectively take to achieve change. So I do see this very much as a model. When we launch State of Care next month, there will be a series of issues that come off the back of that, where we want to use that convening power again to support conversations with ICSs, conversations with different groups. So I do see this as a model where we bring our expertise and our understanding and collectively with system partners and indeed frontline staff, we try to tackle the issues. I think that our goal in driving change and improvement has to be using that power to take those important steps.
Thanks, Chris. Any other questions for the team? Okay, I don't see any others. Well, thank you very much, Ian, Chris, Kate. As Ian said, that was kind of a very updated, very recent activities. So I think we turn now to the corporate performance report, looking back over a longer period of time. Chris Usher, I don't know if you want to introduce this. We will have read the report, so no need to go through vast detail, but please do pick up highlights for us, and then we'll take questions.
Yeah, I'll just open out with a few comments. So just say this is obviously the first quarter's performance report against our new business plan. We've refreshed the dashboard and looked at how we record the RAG status in there. So grateful for any feedback from board members outside of board, or now if you wish, just on the look and feel of that would be good to get some feedback on. I'll just update on a few areas, and then Tyson might want to just talk about performance right up to date, because obviously this is just quarter one review. So just pulling out a few areas. Slide 2 in the deck just continues an eye on the activity we're delivering. So in quarter one, nearly 10% of locations have been inspected or had a DMA call, and nearly 50% have had regulator activity when including our public statements. In terms of give feedback on care, which is on slide 6, we're still receiving high volumes. You can see this reduced slightly in recent months. But interestingly, our positive feedback has been rising over the last 5 months, which we're doing work on just to understand that in more detail. Some interesting trends coming out there. In terms of the following slide, you can see one of the ways in which that can be used, not the exclusive way, but one of the ways it can be used is just around where we are inspecting based on things that we've triggered by risk. And the graph showing that the most common there is information of concern, which can be a variety of things, but also just shows how we're using the intelligence we're gathering to form an action. In slide 13, just on the reports, an interesting downward trend there in terms of our time to publish reports. You can see that's come down by 25% over the last 12 months, so good improvement in that area. And then the last bit for me, for up now, just in terms of finance. So on our revenue budget, we are whilst we're underspent year to date, largely due to the profile of income, we are forecasting an overspend for the year of 6.7 million. That includes expenditure for about 1.9 million of expenditure that we will incur, but we've yet to receive funding from the Department of Health and Social Care for, which is such as work on ICS regulation. Overall, I think it's fair to say we'll continue to monitor our financial position closely and take remedial action to ensure we're in on budget by the end of the year. And that continues over into capital, where we are forecasting a 5.3 million overspend on capital. Again, this also includes funding we've yet to get final confirmation for. We're rating that through shortly, but we'll manage our overall underspend through the portfolio. Tyson, if you want to cover up-to-date performance, and that's it for me. I'll come back to risk at the end of the performance conversation.
Thank you, Chris. And very briefly, I won't repeat what's in the report. I just wanted to thank my colleagues for what I think is a strong performance in August, despite the fact we are right in the heart of our people change now, and colleagues have obviously been wanting to give some time to deciding how to deal with that. I think there's strong performance on registration, and in a number of places we are seeing strong improvements. The number of inspections has increased on July, and I'm hoping that they will continue to increase over September, and we continue to show a strong performance in terms of dealing with whistleblowing and safeguarding inquiries. So the only point I really wanted to make was to thank my colleagues for what I thought was a strong performance given what's going on in the organisation.
Thanks, Tyson. Questions for Chris, Tyson, or the team? Mark.
Thank you, Chairman. Tyson, thanks for the update there, and really good to see the improvement in registration completion times. Congratulations on that. I mean, I did note that inspections had stayed constant, but DMAs had slightly reduced. I just wondered how this mix is going to be managed going forward.
Thank you, Mark. I think there are three reasons why the DMA number is lower than it has been over the last few months. The first one is obviously we're in the August was right at the heart of the annual leave season. And that will start to change as we move into the autumn. Secondly was the change process that I was talking about, and colleagues in the DMA team at Grade A and Grade B will have been going through various people change processes, and we will have ensured that we've given them the time to do that properly, but also the team are now doing DMAs on more complex work, what we have previously described as Band C providers, which is where there may be more concerns being expressed by the data. And the experience is that that's taking longer to do more thoroughly than maybe some of the DMAs on providers in Band 1 and 2. So certainly the annual leave point will change as we move into September and October, and some of the people change dynamics will change. But I'm expecting that the volume will also stay relatively restrained because of the more complex work. But where we can do that more efficiently, we clearly will do.
Thank you, Tyson.
Thanks, Tyson. Could I ask Chris a question as well, Chairman?
Go ahead.
Chris, just in terms of your performance report, and I know it's linked to the business plan measures, but in terms of people, we seem to have lost quite a bit of the data that we've had in previous performance reports. So we've lost turnover by disability and ethnicity. We've lost our insight into our training performance. We've not had a chart on our reasons for leaving, which I think is an important piece of information for us. And no data on promotions and acting ups. So I just wondered whether we're going to see those again, because they're important sort of organisational health measures, and why we wanted greater detail in the past.
Yeah, sure. So we'll bring them to an item at the next board in December, which will bring back a full people plan and include a host of metrics there, such as the ones you're talking to. The reason, unfortunately, we didn't manage to get it into this one and just focused entirely on the business plan measures is simply one around accessibility. So the data, we need to get it in accessible format to ensure it's on our website. So we've not been able to get that, but for the next report in December, we'll have a full suite of metrics on people data for you.
And Chris, just following up on that point, as you introduced, this is kind of based on the business plan, but I mean, you are doing some work at the moment, which partly came out of the Board Effectiveness Review earlier in the year, I think, looking at the information that we would get on a regular basis. So people metrics, I'm assuming, will form a significant or an important part, at least, of that ongoing regular reporting future.
Yeah.
I don't know if nodding came over the microphone, Chris. But
sorry, I could say more of that. I mean, yeah, we are working on a new performance framework in line with the new business plan for April next year. So looking at really how can we review all of our performance measures, how that links with our strategy and how that works through the organisation into everyone's deliverables. And I think there's probably something we need to strengthen just in terms of how we align fully with the strategy and have a golden thread of performance and what we can do to really focus on the outcomes that we're delivering on, as well as just what we can measure and what activity we're delivering on, but actually what difference we're making from that.
Helpful clarification, thank you. Other questions? Again, Robert.
I think this is one for Chris Davis. It's about the give feedback on care slide at page 20. And what is noted there, which is a very substantial increase in positive responses received. And I wonder, we hear a lot about negative responses. Why, can you ascribe, is there a change of methodology or is it simply an uptick in the cheerfulness of the population? What is it about?
I think there's a number of factors in play. Firstly, the figures that we see there are only the online give feedback on care, so they don't reference the full entirety of give feedback on care, some of which comes, albeit from the campaigns, through to the contact centre. So the normal average split is about 80-20. So if you look at the full back, you might expect 20% and 80%, 80% being negative, 20% being positive. I think there are a number of things that play into that. Firstly, we've been trying to do some work on piloting a channel shift in some of the activity. So we've actually seen a net reduction, although you don't see it in these figures, in the phone element of this as it's moved to online. We've also been piloting, and I think this is where substantively this comes from, an approach in the DMA where we've been actively asking the providers to give us feedback. Now, you might say, well, wouldn't they go to people that they know have experienced a better level of care? So I don't think it should be ruled out, but I think it's important to understand. But actually, crucially, it's important to understand. So you just see positive, negative. Actually, why it's positive goes some way to describing what some services and what some systems are doing differently, and actually looking into the reasons behind why are as interested as looking into the reasons behind why services fail. So it still has value. I think we're doing, it's fair to say, talking to Jill and her team, that we're doing some both coaching with college operations and also with providers to make sure that we're confident that the process by which we gather that information. So, for example, using posters that they can ascribe to put up and pointing people towards those. So it's not people collecting that feedback and giving it to us. It's still individuals being prompted to share their feedback. So I think, as I say, I think we'll see perhaps more of it. I think the totals, because the totals look like they dropped online, but actually they've risen on the phone. So there is a bit about looking at the totals of this, which I think we need to try and get back to when we can. But I'm keen that we can look into why the various exists, what changes organisations are bringing about positively as well. But it doesn't. When you look at it compared to the phone, the actual variance is quite small. It's much smaller because there's a bit of a translation across. I think the DMA has a part to play, though, definitely.
But no doubt, whatever the proportion is, it would be useful to know what it is about the organisations that produce genuine positive comments, and one would hope most of them are. which perhaps indicates good practice that should be spread.
I think that's really important, because we went to see Newcastle Trust recently as an executive, and indeed some of the comments we've had have been from that organisation. You can point to things that individual organisations are doing that do lend themselves to a change in people's perception. So I think, going back to the points we've raised earlier, there is good practice out there. It's important we understand why that good practice exists and what about it drives the right behaviour. So I'm very hopeful that we'll use both the poorer practice as well as the good practice to help unlock what we think needs to change.
Thank you.
Thanks, Robert and Chris. Sally.
Thanks, Ian. I had 3 questions, if that's okay. So the first one, as you'd expect me to ask about, is overspend on both revenue and capital. So I appreciate you talked about quite a significant chunk of that being work that we're already doing, that we're awaiting funding on from the Department of Health. So perhaps there's something that somebody would like to say about that. But hopefully, if we do this reprofiling of both transformation programme and our work, we will land back on the number we're supposed to commit to.
Yeah, well, I mean, that's certainly the plan, Sally. So, yes, we're working on that now, both revenue and capital, to bring back in. On the funding side, so we have, later in the report, you'll see we've slightly increased our risk around funding, and it's primarily for that reason. We've had a number of things that we are doing additional this year to implement for future regulation, and we have had funding for most of those, such as local authority assurance being a recent example. So it's probably a low risk in the grand scheme of things, but we are still, as it stands, awaiting funding for ICS, Integrated Care System regulation. We also have COVID inquiry, which we as yet haven't resolved how that will be funded for this year. So there's a few risks there that we've just increased slightly the risk around our funding, which we'll see.
I mean, it's probably worth saying, Sally or Chris, I don't disagree if you will. I mean, we obviously we're very grateful. We understand the difficulties the department has at the moment for a whole bunch of reasons. We're very grateful for the money we have received, and I think the discussions are going well. As a board, we have a challenge, and we're trying to strike a balance here. We are supposed to live within financial disciplines, but we also have to apply some common sense. And I think it would be completely wrong of us just to stop doing things when we have a good reason to believe that in due course funding will be available. So I think it's quite clear. The board's clear that it's moving a little bit away from some of the financial disciplines, but it's the right thing to do. Conversely, some of these approvals which are under discussion are probably taking a bit longer than we want. And I think I hope by the time we meet again in December, you'll be able to report that all of this is resolved and the replan shows it. If not, then obviously one of the difficult things the board will have to address is whether or not there are areas in which we have to curtail our activity in view of the lack of funding. But hopefully that will be not be a problem and sorted out by December. Ian, so I don't know if you want to comment on that.
Yes, just adding to that point, I think I'd just like to give everyone assurance that we're going through the grant and aid funding line by line, looking at exactly what we're doing in terms of grant and aid funding. And the reason, as you described, was that we recognise the difficult funding position that wider government is in. It seems the right thing to do to look and see if we can do things as efficiently as we can. An awful lot of what we do, though, is done effectively as an operational agent on behalf of the Department of Health and Social Care, and in doing that, an awful lot of services are, in fact, volume-driven. So second opinion appointed doctors scheme, for example, under the Mental Health Act, is a good example of that, where we arrange for psychiatrists to go and provide a second opinion for people who are detained under the Mental Health Act. These are important roles, and important that they are done smartly and quickly, because people are detained. So we want to make sure we can continue to maintain that high level of service, but at the same time, as you rightly say, we by the time we meet again in December, I'm hopeful we will have resolved all of these issues one way or the other, and we'll come to you with a package of things that we might need to stop doing, and that there are some things that potentially we may have to come forward and stop doing, or at the very least push into the following financial year. Thanks.
Thank you. Thank you. Yeah, that's really helpful. I had a very specific point around our disability statistics. So it's lower than the general population by quite a lot. And I'm interested to know, or to find out later if you need to investigate, whether it's because we are not recruiting at the same level people who have a disability, or whether we are but staff aren't self-declaring, which is a problem that I've seen elsewhere. So I just wonder whether we've got an answer now, or we just need to think about that when we start to do the next pulse survey and ask some of the questions that Mark raised before about the data that's in here.
So if I can respond, but also, Mark, I don't know whether as execs of the Disability Equality Network you might want to come in as well. Sally, we're pretty confident that we've got an under-disclosure issue, and we've been doing work to encourage our staff to accurately capture their needs that they have so that we can monitor it appropriately. We've also been doing lots of thinking as an exec team when we think about the people changes that are happening within the organisation, that it becomes more of a norm that people, when they get to know a new line manager, they kind of have a way of describing the way that they need to work and how they need to be supported, so that it's just something that everyone has rather than a specific group of people. So I think this is particularly around needing to encourage more people to self-declare. But Mark, I know you spent a lot of time with the Disability Network. Do you want to add to that?
Yeah, thank you. So we have a comprehensive workforce disability equality standards action plan. We've got 9 different work streams in there working towards improving a number of different areas to make this a great place to work for colleagues with disabilities. One of those, which we're launching very shortly, is about declaration. Part of the challenge that we've had up to now has been around our internal systems for recording disabilities. We've made some improvements around that. We're also doing a number of things to make it easier for colleagues through technology and accessible ways of working, but also about attracting talent with colleagues with disabilities. And we're making great progress on those.
Thank you. And my last one was about ratings, because there's a nice chart in there on page 18 which talks about how we've changed ratings when we've responded to risk, and some of those ratings have deteriorated. And perhaps I'm putting together a jigsaw that doesn't exist, but if you put that with some of the messages that are likely to appear in our State of Care report, or some of the issues that we're all familiar with around access to services, our ratings are still quite a high percentage of good or outstanding. So I understand there might be a slight lag, but it might also be that these are biased because we are triggered by risk and therefore go into a service and that service has deteriorated. So I don't think there's an exact answer, but I'm just interested in talking more in the future and at the next board ahead of how the state of care, when we publish that report, and our ratings fit together to present to the public a real kind of honest appreciation of what services are like for them. So it's not really there may be comments that you want to make right now. I think it's just a statement that we probably need to come back to at some stage. Thank you.
Chris, do you want to comment?
Okay. I think it's important I think you're right in the sense that we are, I think about 50% of our inspections are responding to risk at the moment, and they're often going into services that are already inadequate or requires improvement. And I think it's important that we can respond to whistleblowers. It's important that we can respond to give feedback on care in that way. I think what we're finding from our work in State of Care and our wider work around systems is that access to services is a crucial issue at the moment, and it doesn't just affect all services. It's not just about one sector. So I would expect to see over the course of time a greater reference to that, both in our system work and indeed in our individual provider work. I think what we've got at the moment is an important response we're making to risk, which means that we are deliberately diverted to organisations that we know already are inadequate or require improvement, because they pose such a proportionate risk to people who use services. So it's important that we can address those. I think over time, particularly with the new approach, we will be able to offer a wider perspective on people's access and therefore the overall quality of service.
Thanks, Chris. Kate.
Yeah, if I can come in. So just talking about adult social care, Sally. So as Chris says, we've predominantly been going out to risk, but we've also recognised that when new services register with us and haven't yet been rated, that's a priority area as well. So we've been going out to services where we've been worried, and we've been broadly finding those worries to be there, and have been that's been reflected in our ratings. But also a chunk of our activity has been going out to new services, and as you know, we register services where we're confident they will hit the good bar. We're rating them for the first time and they're getting good. So that's why you've got that kind of funny balance in adult social care, where you've got a percentage deteriorating and then you've got a percentage getting their good rating for the first time. And that's at high level, that's broadly the rationale.
Thank you. And I mean, the only thing I would add to that is that quite a lot of our risk activity will involve going to the same provider a number of times as we monitor whether or not they've improved over a period of time. And therefore, the static ratings might not give a completely accurate picture of how many providers in what category we're actually inspecting. So that's another bit of the context, I think.
Thanks, Dyson. Any other questions or comments on this report? I mean, just to close the loop a little bit on a discussion we had earlier, Chris, on performance reporting, and Sally's question and Ian's response, pointing out that, for example, some of the services we provide are volume driven. I think one of the things we've discussed, and useful just to confirm, is that in the reporting, drawing distinction between our internal performance on things where we know we have an outcome to achieve for patients and users of care, but some discretion as to how we do it. So that's one thing. So we have an internal metrics and we can report against them, as opposed to some of the other things where we just are asked to make a facility available and it's volume driven, and we have no, we neither set the terms and conditions in which we do it or the volumes of throughput. So it'd be helpful to draw a distinction out in the future reporting as to those things we can influence and those things we can't. But I think that's picked up in the current project. Yeah. Okay. Well, if there are no further questions, Chris, thank you very much indeed for that, and very helpful summary. Let's move on to one of the most important issues we always have on the agenda, which is the quarterly transformation update. Kate and Mark, I think you'll lead on this, but we should also be being joined by Amy Pritchard, I think. Amy, welcome. I think you know you're on live stream for the public board, so thank you for joining us. Kate, I don't know, are you going to... Kate, are you going to lead on this?
Yeah, I will do. Yeah, thank you. So this is an update of the first quarter of this year for transformation. I'm just going to pick out a couple of highlights from each of the programmes, and then I'm going to talk a little bit about what next, if that's okay. So firstly, on the first pillar, our first programme around our regulatory framework. As you know, this is our new single assessment framework based on what matters to people. A kind of key achievement that has been delivered in the first quarter of this year, running a bit into summer, is our 4 test and learn pilots, for another phrase, of 2 local authorities and 2 integrated care systems, where we've gone out with our new methodology, our new single assessment framework, to test whether we've got the right method for capturing evidence and forming an effective view about how that local authority and how that integrated care system is delivering for people. So that's landed. It's produced a huge amount of important feedback for us that will continue to shape our methodology as we get ready for go live into next financial year. So that's just one thing to celebrate with the first pillar. With the second pillar, which is around organisational design, progress continues to happen around our people changes. So we are continuing to support colleagues to move into deputy director roles within regulatory leadership, deputy director roles within the operations group, and to follow through the implications for people at manager level and for our inspectors, etc. So those people changes are continuing. Our preference exercise closed yesterday for our inspectors, and that's making progress as expected. And then on the final pillar, we've gone live with our new data and insight unit, which is really important that we kind of pause and celebrate as well, because this is a key foundation for enabling us to be that insight-driven organisation where data is helping us shape our regulatory efforts. So that's gone live. And then we also went live in the beginning of August with our first, we call it early adopter, which is where we have tested out our new technology to enable hospices to provide death notifications for us as a regulator, but also for a small number of home care providers to register with us on the portal. So the reason why I say that is there has been a lot of good stuff that's been delivered in the first quarter of this year. But as we move between phases, it's a really good opportunity as well to check in on whether our plan is still the right plan as we move ahead. And the reason why I mention that is for a couple of reasons. Going live with new technology is incredibly complex, and we need to make sure that our plan for how we roll that technology out makes sense. We need to be incredibly sensitive to what our people are going through with their changes. So our people are moving into, I need to say this, we were calling them multidisciplinary teams as a result of a poll that Tyson's led. They're now called integrated assessment and inspection teams. So our people are busily in the next month or two, over autumn, will be moving into new teams, settling in with new line managers. And we need to be really sensitive to that when we are thinking about asking them to adapt to new technology as well. And then you overlay that, our providers who are going to be going into what everyone is anticipating to be the toughest winter. So we need to reflect on all of that when we think about what should the rollout look like for the next 6 to 12 months. And I would ask Board for your support in enabling Amy and I and Mark and other colleagues, Tyson and our teams, to think about have we still got the right timings around that rollout plan, noting the kind of complexity of the technology, our people changes internally, but also what's happening out there for health and social care providers as well. Thank you.
Anything you wish to add?
No, actually, that was very comprehensive. So I think if I could just highlight again the importance of the launch of our Data and Insight Unit. With the Data and Insight Unit being established, we've now got our new enterprise data platform that supports that as well, which is really the start of us becoming an insight-driven organisation, the delivery of that insight that allows us to really focus our regulatory efforts. Really pleased with what the team have been able to achieve there.
Okay, thanks. Sorry, if no one else is. We've talked quite a bit about the technology. I'd just be interested if there was any more to say around the cultural point that was referred to on page 38. I mean, you explained how the cultural principles are woven into work in progress, but clearly this is quite a major challenge for any group of people, never mind the CQC. But I just wondered if you could say a little bit more on where we are compared to the expectations we would have had, say, a year or so ago when the strategy was approved.
Thank you. So, yeah, we are asking a huge amount of our leaders in this organisation to drive our vision that we established in our strategy here, which we launched last May. So, so there's a huge amount for our leaders to digest, but then they are often going through changes themselves while supporting frontline colleagues in the delivery of the day job. And Tyson's earlier reflection about performance still being where we would hope is testament to our inspectors as well as our managers, etc. So there is big adjustments that we need our colleagues to continue to go on the journey with us on, not only in terms of new ways of working within the operations group, but in how we use data and insight and how we grow in confidence and how we use that intelligence to help inform our regulatory work. I think our cultural work is just getting started. I think we've got more to do and more to talk to board about for now. But I just want to recognise, as we sit here today, the kind of huge efforts of our leaders in the organisation that are, carrying on delivering business as usual while adjusting to quite different ways of working that we are asking them in order to ensure that we are an effective regulator that we want to be.
Tyson.
Thank you, and I agree with all that Kate has said. I think we will support our managers and our leaders in terms of training and development needed to help them in this space. And I think when our people come together in their integrated teams, probably in the autumn, I think that will be quite a key moment. And I think one of the new ways of working will be about decisions being taken at the right level. And I think that will be when we will start to see some of the cultural change that we're looking for. So I see that as quite an important milestone.
I was going to follow up, so I'll ask that now, just the question on there is going to be a lot of support and training and development, whatever you said. I just, we're asking for confirmation, I suppose, that we're comfortable with the resources in place to deliver that.
I think over the time frames we've got planned, which is to bring the teams together and then to train them for the rollout of the regulatory platform and the single assessment framework. Yes, the conversations I've been having with our academy is that we've got the resources in place, and clearly we will need to give our people the time they need to do the training properly. That's an area we really can't scrimp and scrape on.
Chris.
Just to add to a point that Kate mentioned about leaders, that's absolutely right. We're asking leaders in the organisation to do an awful lot in terms of continuing business as usual as we think about the future. Can I also call out a group of people who've been acting as champions for some of the changes that we want to take forward, particularly around our use of data and information to guide our judgments, thinking about how that would play out in a multidisciplinary team, thinking about what the shape of that would be for how we make decisions more collectively. There's a group of people, leaders, but also people from across the organisation who have been engaged in that effort. And I think there's a really important story to tell about people's desire to be able to have real-time information, more real-time information, making good decisions, working together. And I think it's important to articulate this. We're not pushing against a sort of a culture that doesn't want this. I think it's just making sure that it's secure, and I think if we can offer the security around how we're going to use the data and information alongside our other activities, if we can once we can see how people will work together to form a view of an area, I think there'll be strong support for both the technology and the new ways of working, because people will know it's what will guide them to make better views, not just of providers, but of systems and services as well. And in the strategy, one of the biggest bits of feedback we had internally was people knew that we needed to have a view of both areas and sectors. And I think this enables that. And there's some important challenges to go through, both in terms of how we organise ourselves and how we deliver the technology to support it. But I think there is a strong desire in the organisation to make that possible, and there are people who are championing that from across the organisation now.
Since you have the floor, it may be going a little bit beyond the scope of this, but we're talking about transformation. You lead on a lot of the external engagement and communications. I wonder if any feedback you'd like to give the board on the views you're picking up in the wider market, particularly those who are going to be subject to our regulation.
So one of the really interesting things about this from an external perspective is that one of the few things that probably binds all the people that we regulate together is their desire to move from just the activity of inspection being the only thing that we do, to providing a service which allows a provider to see where they are relative to other organisations that are like them, that allows them to comment on what's happening to them more in real time and develop a relationship with the organisation that allows for that narrative conversation to build. So there is strong support for the technology. Mark's had the, I hope, pleasure of talking to the executive leaders group that we have from across the sectors that we regulate, talking a bit about what that might look like in terms of a new service for providers. And we've had very strong support for this idea of having a more a greater understanding of how systems and services are working together. So I think, if anything, there's strong support for this, strong support of the idea of moving away from just a regulator that inspects periodically to an organisation that understands how health and care services are changing over time.
Thanks, Chris. Ian.
And if I could just build on that point, certainly the conversations that I've had around this are recognising that about half of the people that we regulate are from the private sector, be that care homes, be that private healthcare, and they feel that ratings and demonstrating improvements are a really vital part of their business and the way they operate, as do many NHS institutions as well. And so what a lot of people want is for us to be able to move ratings forward and be able to come back relatively quickly, do a relatively modest amount of work in order to reflect the very latest position that they feel their organisation is in. And I think what the transformation does, what the work we're doing does, is it puts us in a position where we have the people, the technology and the methodology in order to move those ratings on and reflect that positive picture. Because although there's often we talk about things going wrong in health and social care, the reality is that is true, but there's also an awful lot of really good work going on and an awful lot of really good progress, and people want to use our ratings and our regulatory approach to underpin that and to demonstrate to the wider public that things are improving. So again, I think this is a really important facet of transformation, that ability to move ratings on quite quickly.
Thanks. Yeah. I think that the point about the fact that half of the people regulate the private sector is a really important point. And certainly in my engagement with stakeholders, as I've been meeting people, it's often overlooked right across the piece. Any other questions? Amy, this is really unfair of me, but I'm going to do it anyway. We asked you to come along. We haven't even asked many questions. So any final thoughts on the questions you thought we were going to ask you that you would have asked them here?
I don't have anything to add, really. I've not been to a public board before, so I think you've done a grand job of interrogating me. Everybody's answered the questions, so thank you. Nothing to add.
Great answer, Amy. Thank you very much indeed. Okay, we'll let you go, Amy. That's great. Right. Martin, we're going to get Louisa.
A message to Louise to say we're a little bit early.
So busy looking at my vitrine here, I hadn't realised you walked in. Did it very quietly. Welcome. Right, we're here to have an update from you on Health Watch England. I'm sure that Robert will chip in as we go along. Robert, I don't know whether you want to introduce this more seriously.
Not particularly. It says will be the last time I do this, so I'd just in advance like to record my thanks to Louise for the amazing way she's taken over from Imelda, more than filled the boots that were there. And I think this report will show you how much is being done and the value that Health Watch England brings to the public and indeed to the CQC. But I don't want to steal her glory.
Louise, the floor's yours.
Thank you, Chair. Oops. Thank you, Chair. And thank you very much for that, Robert. I hadn't prepared anything to start the long goodbye, of which we're absolutely heartbroken at Health Watch England that you're leaving. But I'm sure a new chair will be found who'll do the job. Who'll do the job very well. So it's great to be here to present this report. Obviously, I'll take it as read, as always. It's been a very busy summer, as summer often is, even though you hope it's going to be a bit quieter. And this report outlines the influence that Healthwatch England and the Healthwatch Network have brought to bear, based on what people have told us, on some big issues that we've been working on for several years now: access to NHS dentistry, elective weights, and accessible information, amongst other areas. The report also shows how our profile has gone up, which we're very happy about, which in turn supports our influencing and our brand, because we want Healthwatch as a movement to be exceptionally well known, so more and more people come to us with their experience of health and care. The report also shows how we've supported the local Healthwatch network with their capability and capacity, particularly in relation to working across integrated care system footprints. And something that isn't in the report, but we're looking at a couple of further areas for action this autumn and winter. And one is looking at the impact of the cost of living on health, and we're looking at a kind of rolling piece of research, so we gain some input on whether and how the cost of living is impacting on people's health. And also, can Healthwatch England and the Healthwatch Network do more, given the likely unprecedented winter pressures, particularly in the NHS and social care, including, as always, painting a very balanced picture and a very solution-focused picture in terms of the pressures on NHS, and taking into account pressures on NHS staff as well, because that in turn again influences the care that people will receive, and also information and advice on how to best access NHS services over what will be an exceptionally busy period. So happy to answer any questions on the report, Chair.
Sorry, thank you, Louise. Questions for either Louise or Robert? Belinda.
Hi. I just wonder if you could talk a little bit more about the surgical hubs and how you think that will impact on inequalities in healthcare, which you put in your report.
Yes, thank you. We did very much support any new initiatives that aim to reduce the very long backlog, with the record number of people who are waiting for planned care. So diagnostic and surgical hubs we absolutely welcome. The only caveat to that is that if people have to travel a long way to their nearest surgical hub, then we think support should be given to them. Otherwise, that risks creating inequalities for people who find it difficult to travel for lots of reasons, because of pressure of work or cost. So what we've asked is that if you haven't got a surgical hub near you, and that's a good way to get your treatment faster, that you're supported in travelling and in expenses.
And has that been well received, that request?
It's been received.
I think the response said it all, Louise. Thank you.
I think it would be fair to say, Chair, that our experience with dentistry, for instance, to show that sometimes it takes many years and many reports to actually get more than a receipt. But there we go. We do get there in the end.
Thanks. Any other questions? Sally? Oh, no, Robert. Just on that. Sally, then Mark.
Thank you, and thanks, Louise. I just wanted to delve a little bit more into mental health. I thought Belinda might ask, but I'm going to ask anyway. So there's a little paragraph in there which is slightly buried, but has a huge impact. And it says, we've highlighted how the pandemic has exacerbated issues in mental health to such an extent that all the extra money and services developed in recent years is seemingly making little impact in overall experiences of the care that patients have. This briefing has helped feed into early thinking on the NHS long-term plan. So it's quite a stark statement, but with a slightly more positive end about how we feed in. So could you say a little bit more about both of those, perhaps? Thank you.
Yeah, thanks, Sally. So I think, I'm sure people around the table will understand that COVID had a huge impact on mental health in terms of diagnosis across the life course. So for young people, and this is some of the feedback we get from people. So for young people in areas like eating disorders, for example, and then all the way through in terms of, for example, dementia diagnosis. And we know that both COVID seemed to make things very difficult for people, but also then diagnosis became slower, and then access to treatment became slower. So despite mental health investment standard, obviously, which has been an excellent initiative in terms of parity, we've seen demand go up, as with so many other areas in health and care, and the system really kind of unable to cope with the demand, partly because of other issues on workforce and so on. So we're starting to get that, not in huge numbers, but we're starting to get the impact of that and trickle through into our feedback. And unfortunately, that is the case in terms of a range of areas, including cancer, for example, where before the pandemic, people, satisfaction with cancer services from diagnosis through to treatment was high, and we've seen that dip as well. So what we've been doing is an analysis of a range of areas, including mental health, maternity and cancer, specifically for the long-term plan, to show what's changed. And what we do tend to find is if people are actually treated, then their satisfaction, goes back up again, and they're being taken seriously and their conditions being treated. But issues of access and issues of diagnosis are still being reported to us as being problematic. So we have fed that in. I know certainly the NHS England senior team really have listened to that, and we've been in very constructive dialogue about how to support people in that pathway.
Thank you. And I guess in reducing the backlog, which is a priority for the new Secretary of State, it's easier sometimes to fix a physical backlog than it is to fix a mental health backlog, because mental health can be so severe and enduring, can't it? So it makes planning for the future that much more difficult in mental health.
Yes, that's an extremely good point. I mean, I imagine you've discussed this today, but the ABCD, is right. Those are the things that people largely tell us about. Those are the vast majority of feedback we get is about access, it's about care, it's about the backlog, and it's about doctors and dentists. So, we were happy to be able to write to the Secretary of State to say that absolutely reflects what people are worried about, and that absolutely does include mental health as well as physical health.
Any other questions? Sorry, Mark. I'm sorry. You had your hand up before. I didn't even acknowledge it, and I forgot you.
Thank you, Chairman. Louise, great report. Thanks very, very much. I mean, it's just super the way you as an organisation continue to focus on the service user critical areas, so dentistry, mental health, long COVID, winter planning, elective weights. I mean, it's just great to see that continuous focus. Reading the report, what came through was the new quality framework and some really great digital and brand innovations, and your inclusion work. And I just wonder, I mean, these are really informative, really interesting, and I would just like to hear how much HealthWatch and CQC collaborate in these areas, because I think there's a lot that each party can learn from each other. So I just wonder if you could give me some feedback on that.
Thank you, Mark. And thank you for those words of support as well. And I know at HealthWatch England we really appreciate the support of the whole board and executive colleagues at CQC. So the areas like the quality framework and our digital transformation programme were set in train quite a long time before I joined, which was in February, and Robert and the committee and my colleagues in the executive were very clear that one of our roles is to support the 152 local HealthWatch in their capability and their capacity to do their job, because we're on the shoulders. All of the 750,000 pieces of feedback a year that we get, vast majority of that comes in through Local Health Watch. So from a digital transformation point, absolutely crucial that we're able to collect that data in a safe and anonymised way and use it properly to influence policy areas. And the quality framework as well, which also includes supporting Local Health Watch to improve their equality, diversity and inclusion practice. Again, very delighted to have inherited that as a quality assurance piece of work. And there are a range of domains in the quality framework, which include leadership, collaboration, best engagement methods, sustainability, and influence, impact, EDI, as we've spoken about. So we are on a journey to try and ensure that all Local Health Watch undergo the quality framework. So these are the kinds of measures that make the network stronger, they more capable. They do an absolutely excellent job in their local areas, and most of them, of course, also collaborate with the regional CQC teams, and some have a really close working relationship with them. But it is a question that I will take back to the team, because I certainly think more can be done on a local and regional level. We have very good relations nationally here with the CQC team, but on a local level I think it's probably a bit more variable, and certainly with the risk-based inspection approach there's a lot more that Healthwatch can do to work really closely together with CQC regional teams.
Well, I think we're all here violently in agreement with you there, and look forward to hearing that.
Could I perhaps just add on the quality framework point that one of the areas in which it assists is actually in the relationship between Local Health Watch and their commissioning local authority, because it produces a much better understanding of what the commissioners should be looking for and may I say paying for in relation to their local network.
Any other questions? Louise, I had a couple. I think not for the first time in my time on the board. Sally got there first. I think you've answered the question on mental health. Not at all. That saves me asking. So I'm not going to repeat the question. I'll say it again. I've been an observation, perhaps. I mean, clearly it's disappointing from everyone's point of view, not least the government or the funding this, that the additional mental health funding isn't producing the results we'd have liked. But I think anything that we can do to help inform, I mean, you said we're informing the long-term plan, but any further insights we can give as to why that is the case. I mean, from talking to some of the non-profit providers or charities in the sector, as I have done recently, the way they present this is not just mental health, but including mental health, that you get into a sort of spiral, and if things aren't quite right in one area, it then creates a problem in another area. And sometimes there's quite a fine line between it just getting worse or getting better. One's on the cusp of something, and unfortunately, it means with a lot of extra money and thinking you get over the line, and then it doesn't quite happen. But at the margin, some small changes can make quite a difference as to whether you get on top of it or whether it just, or whatever you do, it continues to spiral. So that's a message I've been picking up elsewhere. If you have any observations, fine, but otherwise I would just note the fact that I think any further insights we can give would be great. While I'm on the phone, completely different point. You did mention in here, talk about the new website and the volumes coming in. And you made the point, I believe, if I can find it, that obviously things were affected by COVID and you had requests there. But you did say that traffic is 145% higher than before the pandemic. And I just wondered if there was anything about what people are asking about or inquiring about. It would be helpful to know. So two very unrelated points.
Thanks, Sharon. Really important points on mental health. And actually, in some areas, obviously, the mental health investment standard and the amount of funds going into mental health have made a difference. But the rise in demand, mainly because of COVID, and including people, for example, who are on waiting lists for a very long time or whose long-term conditions have deteriorated, who may also need mental health support, have increased that demand. So certainly one of our asks is of local systems is when people are waiting for up to 2 years or long periods of time, that their mental health is supported in some way and they're referred on to that. So, yeah, I take your and Sally's point that it's something we should really keep an eye on. And on the website, yes, it's great that even though there's been a dip, that we still have a large number of website visitors. And that's one of the good things about our being a provider of information and advice, is that, you know, people didn't stop looking at our website for information and advice. Just, you know, even they came because of COVID, and lots of them have stayed. So that's great. And, you know, we are a significant multiplier of NHS advice. You know, we just put something out on monkeypox, for example. So we're trying to make sure that if people come to us to give feedback, that it's also a place where they can find advice about health and care. So we do a significant amount of digital marketing as well, you know, all the social media, that kind of stuff, which the team are really expert at, and that keeps the numbers up. I would say that I've personally had more of a personal focus on getting into the media in order to make the kind of bigger changes that we want to see. But yeah, that's our front door. So that's the website's our front door. So it's incredibly important.
Sorry, I should probably have said, since it's been raised, just a word on the chair arrangements, so everyone's aware. The Department of Health and Social Care has been running a recruitment campaign for a replacement for Robert, who would also then, as Robert has become an NED on this board, and indeed also looking for a couple of other NEDs to take account of rotation that's going on. That closed about a couple of weeks ago. Obviously, it's still early days in the process, but I think the indication is we had a good interest in the role. So the plan is that there will be, I won't go to all steps in the process, but the plan is that there would be interviews in November, and from that, if there's a good shortlist, that will then go to ministers. Now, after that, it depends on minister availability. So I think we'll be pretty clear we're not going to have a successor for Robert in place the date Robert goes, but we hope, and certainly I'm pushing, that we get one as quickly as we can after that. So I think it's probably helpful just to clarify that. Okay, Louise, thank you. I think it brings us on to a couple of items for formal approval, and then the complaints report at the end. We circulated, and you have the minutes of the previous public board meeting. Any comments on those, or can I take them as agreed?
Agreed.
Okay, thank you very much. There were, no, I think, significant matters arising from approval. Can't actually find the page of my papers here, but I don't believe there were. So unless there's any questions, I'll move on to the approval of matters arising from the board effectiveness review. I'll take this. To remind you, and I'm also partly for reference for people listening in the audience, there was a board effectiveness review carried out probably about 10 months ago now. We considered that internally shortly after my arrival, and we've made some changes internally, most of which I don't think are of relevance to people listening in or to the wider board here. But there are one or two things that do require board approval and change. So there's three of them which are here. So I'll introduce them all very briefly and then take them one by one. People have any questions and for approval. One of them was that we had a desire to have a greater focus on actually, let me start at order. The Regulatory Governance Committee. it hadn't met for a little while, and obviously a huge amount of change going on inside the organisation anyway about our regulatory model. So we decided to spend quite a bit of time looking at what would be appropriate terms of reference. I've worked personally very closely with Mark Chambers as the chair of the committee, and also with the management to come up with the terms of reference before you that we believe will suit the committee's support to the board going forward. And you've seen the paper. It's not going to go through line by line, but it's a combination of continuing assurance of what we're doing, but also, I think, looking externally at evidence, or looking at evidence that may be available internally or externally about the model, and also looking to the future so that we can anticipate regulatory changes. So there's three main items in the RGC terms of reference there. We commend to you. We have recruited a new board secretary who will join us at the beginning of November. There are a number of tasks we would like her to do in order to tidy some things up. And one of them is to review the terms of reference of all of the committees to make sure that they're conform. There are one or two differences between them. So we will come back to you later on with anything arising out of that process. So it's possible that these won't be the very final version, but we believe that these substantively will be what the final things look like. So what we're asking for is approval for these on a substantive interim basis, on the understanding there may be some minor consequential conforming changes later. The second is we have at the moment an Audit and Corporate Governance Committee. For a number of reasons, probably two key ones are discussions coming out of the effectiveness review, but also the committee's own considerations of its role, including from the findings of an internal audit review. We are looking at the way we handle risk, and some changes proposed to the risk framework within the organisation. Some of that may come back to the board in due course, but just as a matter of principle, we felt that it would be useful to recognise that now in the change of name of this committee. The proposal in front of you is this should be an Audit and Risk Committee. I have one minor change on that, reflecting further on some other guidance, including, as it happens, the Cabinet Office proposals. We thought that to call it the Audit and Risk Assurance Committee, because it is there to provide assurance on risk rather than manage risk, which is an executive role. So the recommendation in front of you is to rename the Audit and Corporate Governance Committee as the Audit and Risk Assurance Committee. And the same point on terms of reference. There's no terms of reference in front of you today, but if we have changes there, we'll come back to you. And then last but by no means least is it was suggested it would be useful to reaffirm committee membership in relation to audit and risk assurance. And also we felt that we needed to bolster the Regulatory Governance Committee, which for a whole bunch of reasons only had a couple of members. So we are proposing that Belinda and Stephen Marston should join that committee, and both have accepted their willingness to do so. So that was my introduction to the topics. Perhaps if I just take them in order. The Regulatory Governance Committee, any comments on those terms of reference, or can we approve them? Approved? Okay, thank you very much. Probably the least controversial, less controversial, the change of name to the Audit and Risk Assurance Committee. Everybody comfortable with that? And I'll say it's only a change of name, but it does reflect, I think, a shift in emphasis of what the committee will be doing going forward. And then, last but by no means least, approval for the members of those two important committees working on behalf of the wider board. Everybody comfortable with that? Okay, well, thank you very much, everybody. I didn't have any other business to add to the agenda, so I'll just check that before we come to the complaints report. Are there any other matters that people wanted to raise? No? Well, Rebecca, I think the last item on the agenda is you and Peter, welcome, to talk about the annual complaints report.
Thanks, Ian. So I'll give a very brief introduction, and then we've got Mita here, who heads up the complaints team, who can answer any questions. So this isn't our first complaints report, but it's the first one we've done in public. So previously we've done an internal report, but it seems important to put into public as much as we can. So I hope this is a welcome initiative. The report pulls out both the facts and figures about our individual complaint resolution, and also I hope it gives the board a flavour of the broader work that the team does with the organisation in terms of learning and improvement, and highlights the kind of quite extensive project and collaboration work that's gone on over the year. So I'm not going to repeat what's in the report, perhaps just to say, if it's helpful, you can see that the numbers dropped during the pandemic, so we're kind of similar to last year, and that the majority of complaints continue to be about the conduct of inspections and complaints about our administrative processes. So probably this year isn't radically different from last year in terms of trends, but you've got hopefully welcome detail there about in-year improvement work and a little bit of the thematics that Mita's drawn out for you.
Okay, thank you, Rebecca. Rebecca, just before we go to questions, Mita, is there anything you wanted to add to that? Or?
I've got a few points that I'd like to share with the board, if that's okay.
Yes, go ahead.
Yeah, thank you very much. Good afternoon, everyone. Just in terms of the themes, as Rebecca highlighted, the main theme in terms of our performance and inspection-related activity, or CQC's handling of concerns about a service, these main themes have not changed over the last few years and is a consistent type of complaint which we handle. Often our complaints processes are also seen as an alternative procedure by which to remedy matters pertaining to inspections, reports or judgments, but we encourage providers to use the processes that are in place to handle such issues. Similarly so, we also advise the public that complaints about services are not managed or overseen by us in the National Complaints Team, and we also refer these on. In all instances where a complaint is made to us, we offer our customers an explanation and signpost them to other processes or organisations who they can take their complaint up with. I think it's also important to stress that we have built into our processes ways in which colleagues who may be the subject of the complaint can be supported. This is to ensure their well-being and to provide some assurance of being valued and being looked after through the process. In terms of transformation, we will report on any themes and trends which we identify in future reports. Turning just to improvements, with each complaint we seek to address the issue for the customer, and we do this by offering an explanation and an apology if we make a mistake. What the report has intended to highlight is how we also stay connected with other improvements and changes which are taking place across the organisation. So we may share this with the customer to provide them with some additional assurance. We do this in several ways, by reviewing intranet updates, the bulletin, seeking information from policy or business leads, and other ways which we stay connected is through improvement, through direct collaboration or working groups or quality projects, and by exchanging information and data. Just over the last year, we received no adverse findings from the Parliamentary and Health Service Ombudsman's Office. However, they do have a number of cases open at this time, which have not been concluded. Reporting on those will be included in future reports. Separately, I'm a member of the Parliamentary Health Service Ombudsman's Working Group, looking at and devising a new NHS complaint standards framework, essentially a gold standard of good complaints handling. One of the ambitions of the framework is to ensure greater consistency in complaints handling by organisations in their remit. They are also in discussion with our policy leads for assessing provider-level complaints handling, but also they're looking to extend this framework to government departments and arm-length organisations like us in future. This is really helpful insights for us as an organisation, and we can use the framework to further align our processes to their guiding principles. And finally, we gather and record all compliments about CQC and share this with senior management to recognise our good practice and interactions with providers or the public. Thank you very much.
Okay, thanks very much indeed. Questions for Rebecca or Mita? Robert.
Thank you for this report, and I welcome this being in the public board meeting. It's transparency, which is something that all organisations should follow, in the public sector at least. Two improvements which seem to be allied here, which you mentioned. One is about the buddy scheme, and the other is your liaison with trade unions about support for colleagues. And I just wondered if you might say a word or two about what effect and impact the sort of complaints we get can have on colleagues.
Very good question. I think most people feel that they're adequately supported through their line management structure because we have independence in the process. So managers are there to support individuals who are the subject of a complaint. Frequently people do use these other schemes. I think a lot of people do find it quite upsetting, I think, to be at the centre of a complaint, and they worry about it. I think what we try to do is to give them assurance, and we're also available within the team to provide that level of assurance to people as well. I think sometimes timeliness of an investigation, so if it takes longer than what we anticipate, can prolong some of that worry and anxiety for individuals. But with all these mechanisms that we have in place, we try to support at the front end, but also there's the wellbeing supporting mechanisms as well available to people to use.
Sorry, I've just got a moment. Implore the patience of colleagues. One of the issues I always think about complaints procedures, whether they be ours or anyone else's, they are inherently adversarial. Someone complains, there's a response, and so on. And I wonder whether we have in our system, or whether we ought to be looking at, particularly the complaints that are about conduct on an inspection and that sort of thing, which often probably are about misunderstandings, whether more can be done or is done about to resolve them informally, sometimes by actually bringing people together rather than separating them by sheaves of correspondence.
Absolutely. I think that's one of the things that we do actually try to encourage. We try to encourage those local discussions between inspection managers and senior management locally with the particular providers as well, to iron out some of those issues and to probably also understand how well and what we do during an inspection, so that's widely understood. I think perhaps there's some misconceptions around that. I think there was a particular leaflet, flyer, that what to expect out of an inspection, and I think that's something that we're looking to promote quite widely as well, so that it kind of addresses some of those new points about how people feel when they go out and inspect and what providers can expect from us as well.
Stephen, Mark.
Really to follow up the same point, because I'm interested in whether there's a different type of sort of feedback loop that tries to look at the sort of the common patterns and themes in this. So as well as supporting the individual in the individual investigation, and we're sort of drawing this together so that inspectors and assessors are sort of aware these are common trigger points. This is what sometimes happens. Just sort of be aware that these are common trigger points. Particularly perhaps if there's a pattern in the ones that you uphold. So, you know, if you get a complaint and it's dismissed, that's one thing. If you get a complaint and it's upheld, and you can see a pattern in the behaviours that are generating the ones that you uphold, how does that feedback loop? Does that make sense as a question?
Absolutely, yes. So this is I think it's a twofold question actually. So one of the things that we're looking to do, and we have done this in the past, is if we picked up, we have, dare I say, a spreadsheet that records also the names of individuals who've been complained about. So if we get that kind of repeat pattern pertaining to particular individuals or colleagues, that's something that we will highlight to the senior management and team. Thankfully, over all these years, we've not had to really do that, but it is something that we have a mechanism in place to report back so we can pick that up. The second part of it is in terms of how we... sorry, I've lost the second part of it. Can you just repeat it, please?
Well, it's where you're seeing patterns in the trigger points, the circumstances that tend to generate complaints. How do you sort of group that together, just to raise awareness that these are the types of trigger points? Be aware when you go into an inspection that could happen.
So this forms part of our other ongoing work that we do. We tend to do a lot of presentations across the organisation, particularly so in adult social care, for example, which is the area that generates sort of like the most level of complaints that we receive. And we try to engage with the teams to make them aware of these kind of thematic things as well. We also present reports on a monthly basis to all relevant directors across the organisation where we have complaints made in their particular areas. So there's that higher level, obviously, awareness raising going on as well, where we can share information.
Mark.
I would echo Robert's point in that complaints are a fantastic lens on how you're really doing. This is where the rubber hits the road when people are not happy with their experience of dealing with the organisation, and it's a tremendous learning experience. And the more open and transparent we can be about the learnings and the insights that we get from this, the better we will be. So great that this is being reported on in granular detail, and great that we're seeing it here and we're doing it in the public board. I think that's terrific. Two things that I think I would have liked to have as this moves forward, that I would probably like to have seen. It's helpful to see the themes and improvement highlights and that sort of general description of how we respond to this. But for the 57 that were upheld or partially upheld, I think I'd want some sort of assurance that the recommended actions in each case were delivered and carried through. That's obviously, you describe how it happens, but that sort of assurance that they'd all been closed out would be helpful. Secondly, I see that a small, very small number of the complaints received related to whistleblowing situations. Those are obviously ones that we should really laser in on. I don't know whether those were ones which were upheld or partially upheld in any way, but almost regardless whether they were or weren't, they will be learning experiences. And if there's any aspect of that where there was some substance to the complaint, we should I think hear about that in some detail and make sure that we are doing all that we can to be a listening and responding organisation.
Okay. Thank you, that's really helpful. So just in terms of addressing the point about assurance, one of the things that we tend to do, and I'm sorry it's not obviously included in the report, but we will not close a complaint until we've implemented any recommendations. So that complaint will stay open on our systems until such time that we've implemented the respective action pertaining to that particular complaint. And if we're not able to do it at the time when we've concluded that particular investigation, we will always go back to the customer to let them know we have now implemented this particular action. So there's that whole feedback loop of making sure that we say what we said we were going to do as part of the investigation. In terms of the whistleblowing complaints, I don't off the top of my head know the detail about whether they were upheld or not upheld, but that's something I will take away and obviously review for future reporting.
Okay, thanks for the comment, Mark, and the response. Mita, any other questions or comments? Mita, just a couple from me. As usual, the first one's half been dealt with already, but I was pleased to see that you did pick up in your remarks the comment about support for people. I mean, as you say, it can be a distressing experience, whatever the role of the individual. Just to follow on what you already said, though, if somebody has been through that process, I mean, clearly, if the thing's upheld, there may be some action for the individual. That's one thing. But if the complaint is not upheld, at one level it's dealt with and your system closes it down, but that doesn't mean to say that the individual is entirely happy about it. So I just wondered if you could say a little bit more about what happens when it's closed if we've determined that the complaint wasn't valid in the first place, particularly because some of these things can get quite unpleasant and personal the way they're phrased. So that was one thing. And the other, I'm just a bit of confirmation, but you did talk about the PHSO guidance, which I'm very familiar with from a previous role. And you talked about sitting on the working group, which is great. You said, I mean, clearly this is designed primarily for the NHS, but you said it would ultimately apply to ALBs. Can I take it from what you're saying that you wouldn't, would there be any changes to what we're doing if the current ways of thinking for trust were to be implemented here? Or I think I was implying from what you said, or I thought you were implying there wouldn't be change, but if there isn't any, perhaps you'd confirm that. Thanks.
So yes, the answer is yes to the latter question in terms of the coming under the jurisdiction. We will be working on the framework just to align it even further, I think. I think we operate a fairly consistent and aligned complaints process to the current complaints handling principles that the PHSO have, but there's no harm in revisiting that just to make sure. So yes, we will come under that remit as well in future. Oh, sorry, and the other point about complaints where they're sort of not valid. It's a tricky one, because once the complaint's done, we generally don't tend to get a lot of feedback. I think some of the issues arise where there might be challenging situations or individuals whose behaviours are particularly unreasonable, perhaps, in terms of how they've engaged. So that work takes outside of complaints process, and generally what tends to happen is that senior management, perhaps say if it's in the inspection team, the head of inspection may decide to have a conversation with the individual or the provider, wherever the complaints come from, to talk about how they would like to have a better sort of alignment in terms and balance in terms of our relationship and how we want to work together. I think there's other mechanisms as well that we do use across CQC. There's the personal safety register as well, which reports perhaps particular individuals who may be displaying behaviours which are really quite unreasonable to us as an organisation. So we have that. We also have our frequent contact and unreasonable customer policy as well, which we can also use to perhaps signal to individuals that there are certain behaviours, etc., that we won't accept, which aligns to our zero tolerance policy that we have as an organisation.
Thank you very much. So I'll look around again. Any last questions? Okay, well, Mita, thank you very much indeed for joining us. Very helpful to see it, and just echoing comments of other colleagues, thank the executive for bringing this into the public domain. I think that's entirely appropriate. So glad to see it. Thank you.
Very much.
I think that ends the formal business of the meeting. But as you know, we do give members of the public an opportunity to ask questions, and we have several. So I might just read the questions out, and then we've identified a member of the executive team who might be best placed to answer it. It's 3 from Robin Pike and 1 from Jade Taylor. I'll take them one by one because different people are answering. So first one, Robin Pike asks what steps CQC can take to enhance its reputation with the public. Chris.
So I just want to give you some background information first. So a lot of our reputation is built around trust, and we take part in an annual survey work with other organisations across health and care, and indeed other organisations in government. And our trust score, I'm happy to say, has continued to remain strong despite changes to other parts of wider government. So our trust score about this, do people feel that CQC is on the side of people who use services, is at 78%. While 78% isn't 100%, it's significantly greater than other organisations of a comparable size. But there is an issue about how we, and I think that's partly led to the rise that we've seen in give feedback on care over the last couple of years. There is a challenge of how do we sustain that. So just to talk through some of the things that we are doing specifically. We've mentioned a couple of times in this conversation and elsewhere, listening and acting on the feedback we receive about care. So I think I said earlier that almost half of our responsive inspections are related to feedback that we receive from people who use services or from whistleblowers. And I think demonstrating that we are using and acting on that information from the public is critical. I think the other thing that's important is ensuring that we focus on what is important to the public. So at the moment we're particularly focused on urgent emergency care, maternity and services for people with mental health, learning disabilities and autism. All of those areas are things that we've had strong feedback from the public, and they recognise that we are both seeking to protect people from poor care and also seeking to take swift action. So an important message in terms of the work that we undertake. The third area is reporting the outputs in a clear and simple way. And my team are currently looking at how we improve the outcome of reports. So there's a clear and simple focus on what people who use services want and inspect. There's more work we need to do on raising the awareness of CQC's role and purpose. We talked in the earlier part of this discussion to colleagues from Health Watch, and in partnership with them and a number of other organisations, we've launched a Tell Us About Your Care campaign this year, which seeks to go where people are. So rather than waiting for people to use our services as a regulator, trying to be where people are at the point where they need support from us, I think is critical. So encouraging people, encouraging partner organisations to share our information so that we can collectively gain a better understanding of how services are working, and that also culminates in the 4,000 Voices work that I mentioned earlier. All of that, I think, being where people are, making sure that we've acted on people's feedback and providing better information to the public will enhance not so much our reputation, it's actually our action. I think that this is beyond the organisation's reputation. So our very ability to act is based upon how we get that information from the public. So I think we've seen a rise over the last few years. I'm hopeful that the action we'll take with partners moving forward will see that grow and grow.
Thanks, Chris. Already a very full answer, but the risk of stating the obvious, the whole point of the strategy is to provide a better service ultimately for users of the system. So one would hope that also as a step towards enhancing our reputation for doing a better job. The second question from Mr. Pike is, how is CQC currently regulating ambulance trusts? I would normally turn to Sean for that, but as I mentioned at the beginning, he's on vacation. So Tyson, can I ask you to respond, please?
Of course. Thank you, Ian, and thank you for the question. I mean, it's clear there have been unprecedented pressures on the ambulance system over recent months, and we remain vigilant to that. We are monitoring risk very closely, and that includes response times and handover delays, looking for assurances that services are doing all they can to be responsive and timely given the pressures. I think it's fair to say we have adopted a twin-track approach to this. Firstly, we continue our risk-based inspections, and we've undertaken a number over recent months focused particularly on the safe, well-led and cultural elements. We've also included ambulance services in our recent inspections of 10 urgent and emergency care pathways. And secondly, the second part of our approach is to support the work that others are doing in this space, in particular NHS England, who clearly have the ambulance sector on their improvement radar, and we work closely with them, and the National Guardian's Office, who are undertaking a speak-up review of the culture within ambulance trusts. So in the round, that's our approach to regulation of ambulances at the moment.
Okay, thank you, Tyson. And actually, I think the last one is from Mr. Pike is for you as well. The question is, how is our Newcastle office performing in respect of its response to telephone calls?
Thank you again for the question. I'm very happy to pick up on that. I think it's fair to say that colleagues in the National Customer Service Centre continue to perform well in terms of responding to telephone calls. Depending upon the type of inquiry, between 87% and 92% of calls are answered. And I think the most important metric is the average waiting time for the calls to be answered. And there are 4 different types of calls that the teams process. Firstly, the waiting time is under 2 minutes for Mental Health Act calls. It's just over 2 minutes for safeguarding calls. It's 6 minutes for registration calls and 4 minutes for more general inquiries.
Okay, thank you very much. So those are Mr. Pike's questions. One last question. This one's from Jay Taylor. It's quite a long question. I'm going to ask Ian Trenham to respond to it. But the question was, as an employer, in cases where the CQC has lost an employment tribunal with regards to whistleblowing, will CQC act as a role model for the system, accept the judgment and decline to then take employment tribunal cases to appeal? Out of the rider, this would protect patients, save the public purse, and developing a learning culture. So quite a long question, but Ian.
Thanks very much, Ian. This, I think, Jade is referring to the recent case involving Mr. Kumar. Just for clarity, we're not appealing that judgment, and I have no intention of doing that. I think it is worth saying we have very few employment tribunal cases in the round. We have a handful at any one time, and very few of them actually proceed to a tribunal. I think it would be difficult for us to make a blanket statement that we were never going to appeal an employment tribunal, but I think it would be something that would be really very much by exception. So I think it is something we take very seriously. But thank you for the question, Jade. Thank you.
Yes, and just to add, it did link it to the public purse. That is something we have to take account of. But I think that does mean we have to look at each case on its merits rather than making blanket statements about what we would or wouldn't do. So thank you, Ian. Having concluded the questions, I hope those answers were helpful. That concludes this meeting. So details of our next meeting, which will be in December, will be posted in due course, including the papers. So for those of you listening in, thank you very much indeed for joining us. We hope you found it interesting, and we'll see you again shortly. Thank you.